Hi, my name is Anya, and we're going to conduct a musculoskeletal examination. So these are the basic techniques in doing a musculoskeletal system exam assessment from head to toe. So we're going to start with the hands and your wrist. Okay. First, as always, I will do inspection and observation with the patient. First, as always, I'll start with the fingers and the patient's wrist and hand. Initially, when you start the musculoskeletal examination, whatever system or body area you're looking for, you're looking at, you always want to begin with an examination or observation of the joints itself, and then surrounding structures, so the fingers and wrist. Inspect them for any nodules, any masses, any gross deformity, redness, swelling. Okay, so after inspection, we will then palpate the distal and the proximal joint for tenderness, lumps, and may indicate rheumatoid arthritis. Unlikely with a young patient like him, but it's always good to have a habit in getting into. So we're just gonna palpate for any tenderness. Other one. We can just focus so we can see everything. Okay. So the next step after palpation is the joint range of motion. So the hand range of motion is really extension. So Kai, can you raise your fingers up in the ceiling? And then flexion. And then face a little bit here so that they can, okay. So flexion and then extension. Okay. And then we'll do the fingers and then adduction and abduction. So adduction, Kai, will be, no, adduction, no. So this is abduction, abduct, and then adduct. Yeah. So that's like the moving the fingers away from the midline and spread the fingers out. That is abduction, and then abduction. What is this? Is abduction and then adduction. Okay, so you are adding the abduction, you're adding in the patient's body, so it's bringing things closer to his body. This is the range of motion of the fingers. So do it again, Kai. Flexion, no, sorry, flexion, extension, abduction, and adduction. Okay, thank you. So the range of motion, if the wrist is similar, it's flexion, extension, abduction, and adduction again. So have the wrist move away from, so let's do the flexion and extension of your wrist. So Kai, flexion, Kai, and extension. Okay? Okay. And then, so let's do the, have the patients move away from the midline and then the wrist toward the outside, away from midline. So that's gonna be adduction and abduction. Okay, in abduction, sorry, adduction and abduction. Okay, so you would think that with the wrist that there is like a pronation and supination, but actually there's not. For the fingers and wrist, there's no supination and pronation. There are a couple of tests that we can learn involving the hands and wrist. So first one is we're gonna palpate your anatomical snuff box. To do this, I'll have the patient extend his thumb laterally away from his hand. Okay, let's do that, away from your hand. So just straight it up like that, and then tuck it like there, away from their hand. And then when you see a little notch in here, a little notch here that is becoming apparent, it is even more apparent here when the depression between the base of the thumb okay? Then you can press on that thumb area, and then if the patient complains of pain, that can indicate a navicular fracture of the hand, and that doesn't get much of the blood supply. So if there's a fracture, it is pretty much slowly healing and sometimes can lead into a necrosis, bone death. So you would want to identify those. Okay, so it's the same with the hand, with the other hand. Honestly, like just like that, and then you extend it, and then this is the notch, and then you press on it. If there is pain, then there's probably a fracture on that area. So the other test, special test, involves the carpal tunnel syndrome. It is a common reason people seek for wrist pain. For wrist pain in hand, there's like a numbness and a couple of special tests that we call the tunnel sign. So you must likely hyperextend the wrist and palpate. Hyperextend, Kai? Wait, no, hyperextend, okay. Yeah, and then palpate slightly over the carpal tunnel syndrome, which is between the midline, between the radial and the ulnar bones. So it's just on that side, so you palpate it. Okay, and then in this side it's the same. So if the patient complains of any pain in that area, then it's positive that the patient can indicate like a carpal tunnel syndrome. So another test for the carpal tunnel is the salience test, and this can be done by putting the patient's hand in a prayer mode position, or alternatively the reverse prayer position. Okay, so you will have the patient have that be on that position, and then count 1 to 30 seconds, and then so while the patient is on a reverse praying position, he would like push it toward each other, and if he starts feeling the numbness, pain, tingling of the median nerve distribution, then it indicates a carpal tunnel syndrome. Kai, can you do a prayer, just prayer position? We can do the reverse one, and then press it like 30 seconds to each other. You can face her because she doesn't want to face the camera, the air. Okay, 1, 2, 3. So, like what I said, if the patient complains of pain while doing that, then it can indicate like carpal tunnel syndrome. So the last test for the carpal tunnel syndrome is what we call the median compression test. So compress the nerve in the tunnel where it sits. Compress it with the thumb for 30 seconds and ask the patient if there is pain, numbness, or tingling. If there is, with the correct distribution, that can also indicate a carpal tunnel syndrome. So, yeah, here. Okay, so the next one we'll be doing the Finkel test, which is a test for the decurvens tenosynovitis. So I will have the patient make a fist and tuck the thumb under the fist, and then I would gently take his fist and extend the wrist and put the stress on the area. Okay, so do this. Yeah. Okay, and then extend the wrist, extend this one, and then, okay. If there was a pain or tenderness in that area, it can indicate a common tenosynovitis called the decurvens tenovysitis. This is common with the graduate students because they type and like write quite a bit. So the next one will be one of the tests that we do for a tunnel carpal syndrome is what we call the Allen's test. This is to test if the vascular flow of the hand. Have the patient make a fist and then occlude both of the arteries, which is the radial and the ulna. Okay, radial and the ulna. I will let him open his fist, and you will see the fist. It's kind of sort of like blanch. If he release one side, if I release one side, then the other side will turn pink within a couple of minutes. So, and I will do that again in the other side. So make a fist. So make a fist, and then I will occlude those sides. And then I will release my one side, and then you will slowly see that it slowly pinks down. So I'll do the same thing, make a fist, and then I will release the other side again, and then I will ask him to open, extend his hand while I'm releasing the other side, and then it will slowly pink up again. I will do the same thing with the other hand, make a fist, and then release. Okay, so make a fist again, and also slowly release. So you can see that it slowly pinks up again. So that's what we call the Allen's test. That is commonly done for procedure with that is commonly done for testing for pain. So before we puncture or do the arterial blood gas, we should do this test before we do the arterial blood gas. So next is we're going to do the elbow. We're going to do the elbow. Again, we will start with inspection. So, pwede ka mo ato ani dapit in this area, right there. No. Yeah, okay. Good. So the elbow. Again, I will start with inspection. Palayo, please. Inspect the elbow for the deformities. Any swelling, redness, and tenderness. I will palpate the acromion process, which is just that part of the elbow, and then the medial and the lateral epicondyle. Okay, so this is the acromion process, and the medial and the lateral epicondyle. Okay, and then I will palpate both for tenderness or for pain. If there is pain and tenderness, then there could be, it's indicative of somewhat what we call the golfers or the golfers or tennis elbow. So medial and lateral epicondylitis, okay? So, so the range of motion for the elbow is actually just flexion and extension, and pronation and supination. Okay, so it is pretty much easy for the elbow range of motion. So Kai, can you do a flexion, extension, okay, pronation, and supination. Good job. So next is we're gonna do the shoulder. So the shoulder is one of the most complex joints in the body. Again, with all the systems, we are looking for the joints first. We're looking for gross deformity, if there's redness, if there's swelling, abnormalities. Like if it's if the patient's shoulder was dislocated, you would actually see it hanging down the lower, whichever is like affected, and then you're looking for symmetry from one side to the next side. Okay. So the next step is to palpate the area. We're going to start with a suprasternal notch and walk our fingers laterally along the clavicle until we reach the summit of the shoulder. So this is the suprasternal notch, and then you walk your hand toward this side to the top, which is the summit of the shoulder, and the little bone up in the top called the acromion process, which is actually the part of the scapula, and it comes down in here and meets it meets up with the clavicle. And just the medial in the little ridge here is the acroclavicular junction, is the HT joint. We call the acromion clavicular joint. So the AC joint is just the medial of the acromion process. From there, if you move your hands down slightly into the pectoral, that is the delta pectoral groove, where it's going to feel the coracoid process. From the coracoid process, you move your hands laterally to the lesser tubercle and the greater tubercle. So those are the main structure of the shoulder. They are identified to they're identifiable for someone whose anatomical landmarks are easy to identify. Someone who is overweight or someone who's muscular, it's probably hard to like look at this anatomical structure. Okay, so it's the same in this side, the suprasternal notch, and then you walk into the tip of the summit of the acromion, and then the same as the feature for this one, and then the lesser tubercle and the greater tubercle. So the next step is the range of motion. Again, we are inspecting. We should inspect the shoulder as well as this for both shoulders through a range of motion. So you would obviously I will do both sides and compare both of the range of motion of the shoulder. So we'll start we'll start with bringing your arm behind you and then abduct and adduct in a way towards the body. Again, abduction is abduction and adduction kind. So abduct and adduction. So you're going to cross, abduction and adduction. This is also called the cross arm test, Kai. The cross arm test, okay? And then do it on the other side. Okay, the chest and then the cross arm test. This is actually a test for the rotator cuff and some impingement syndrome. As you are asking the patient, as I'm asking Kai to go through the range of motion, I can assess the structures of the spine of the shoulder to have the flexion and extension, abduction and adduction, and then internal rotation. So to test this, have the patient scratch your neck. Do it on the other side. No, do it on the other side, scratch your neck. And then reach for your scapula. Reach for your scapula and then do the other side again. Reach for your scapula. Okay, good. Good job. Okay, so now, so that's what we call the opposite scapula. That's what we call the Apolli scratch test. So that is another test that we can perform while the patient is going through the range of motion. That is for the rotator cuff injuries, as well as the range of motion of the shoulder. So there are a few special tests that we should know that involves the shoulder. So you would do this if you suspect any shoulder injuries. Any shoulder injuries and pain, and especially if the rotator cuff injuries. So the first one is the speed test. So Kai, put your hand in a closed fist, position upward, and then I will press down. I will press down with my palms, and then you're not gonna let me, okay? So it needs to maintain a position. This is stressing the biceps and the bicipital grove for tenderness. So this would be painful if the patient has any issues or tendinitis or even a labrum tear on the shoulder. So, okay, so I did the left side. Okay, left side. I'll do both. Good. So the next technique is called what we call the Neer's test. So I will place my hand on the patient's scapula. So I will put my patient's hands on my patient and the patient's scapula. You can face a little bit there. At the Drispicus area, please. Okay, there. As your arm extends a lot, so a lot of times your scapula will be moving along with it. So, Kai, move a little bit. You can actually put your feet on here. So you can like, okay, so just straighten. So yeah, there. Scapula, move along. We don't want to isolate this shoulder. So if I'm pressing down, it should be a little bit lighter, so that when have the patient slightly pronate the arm when he's lifting his hand. So if that causes pain, that indicates a pinchment or the rotator cuff disorder. So Kai, slowly lift your hands like that. So I will push on a little bit, and then you can pronate your hand, okay? Kai, pronate it. Pronate, no, just lift and then pronate. Okay, so I'm gonna do the other one in the same side. Kung pwede mo, bubaling ka nila. Okay, Kai, push that side, and then on that side, and then, okay. So, ano lang ka? Okay, so that's what we call the NIRS test. So you can put your feet out again. And then the next test will be called the Hawkins test. So again, have the patient reflex the outer shoulder and flex the elbow in this position. The arm in the same position over the shoulder. If the patient has a rotator cuff injury, that should be painful. So Hawkins test, have the patient flex the outer shoulder and flex the elbow in this position. Okay. Okay. Okay, wait. So again, have the patient flex the outer shoulder and flex the outer shoulder and elbow and the arm in the same position. Gently over the shoulder. Over the shoulder, Kai. Over the shoulder. And if the patient has a rotator cuff injury, then that hurts. So do the other side again. Okay? So the last view of the shoulder examination is what we call the apprehension test. So this test is done by hyperextending gently over rotating the shoulder. Put the patient in a kind of a baseball pitcher position, throw position in the shoulder, and flex the elbow slightly over and rotate and lift the arm. So Kai, can you just lift a little bit there? So do this. Yeah, so do that. Wait. Okay, and then I will like slowly extend it. Kai. Hyperextend it. Okay. So we'll do the other on the other side. So in your baseball position, and then I will slightly extend it. Okay. Okay. So if the patient complains of any discomfort or pain when I'm doing that, that is a positive sign that there is a shoulder injury. So another test of the shoulder is what we call the drop arm sign. Have the patient extend her arm out on the side and have her extend his arm out on the side again, and then slowly drop the arm. So if the patient, while he's slowly dropping his arm, complains of any pain or is having a hard time dropping it, and that will indicate that there is a tear in the rotator cuff or rotator cuff of the rotator cuff or rotator cuff damage. So Kai, move a little bit there. Okay, so Kai, extend it. Can we take, yeah, he's here. Okay, can we go over a little bit here? Okay, and then you will extend, and then you will slowly drop it. Okay, just straight. So up, and then slowly. Okay, and then the other side, and slowly drop it. Again, and then maybe you can just like do here. Yeah, there you go. Okay, good. So the next is we're gonna do the neck muscle. So we start with the spine examination, starting with the neck again, inspecting and then palpating in different structure, looking for warmth, tenderness, symmetry of the side, looking at the interior of the neck, making sure that the muscle are aligned, the trachea is in the midline, put the next and put it in a range of motion. So now I'm just gonna look for any issues with the neck. So I can see that there's nothing there, everything looks good. So the next is I will put the neck on a range of motion. So Kai, can you please tuck your neck? Tuck your neck. And then extend. Okay, good. And then go in the other side. He's here in this and so you just place there. And then on the other side, please. And then do a big circle. Okay, so this is the best way to see for the range of motion for the neck. If you forgot to like do it, like it's good to just to make the patient do a big neck circles. Okay, so moving on to the next, to the spine. So I will have the patient stand up and have him face front, get behind the patient next to his spine. I will first look at the curvature of the spine, and I will be looking at the cervical spine and the thoracic spine. So the cervical spine should be slightly concave and the thoracic spine should be slightly convex. Then going towards the lumbar, there should be nice natural lordosis and convectivity. Kai, can you just stand up, face over there? Okay, face over there. So that should be, or here. So that should be the same, like here, everything looks the same, the curvature. So then going towards down the lumbar should be a nice natural lordosis or convectivity. Again, down the lumbar spine, there should be an S. So S sign on the curve of the spine where it goes in, and then again, it has founded that you need to inspect first always. So the spine looking on any gross deformities and redness and signs of infection, and palpate. Wait. So it looks like there's no signs of infection. It feels okay. So starting on the C7, the prominent of the bony vertebra that sticks out, and walk your finger down along the vertebra, asking if there is some pain. Is there any pain? Okay. So and also you would like to feel for any depression that's sticking out, which can indicate spondylolisthesis. Okay, so after you have done that, you will want to palpate the muscles, the pair of the vertebral muscles, and the side of the spine, any muscle rigidity, and any pain in the range of motion of the spine. So the spinal range of motion is forward flexion. So I will have the patient flex forward. He can do it by probably touching his toes. So this is a good time to check for scoliosis and making sure that the spine from C7 down to the ridge of the spine to the buttocks area, the natal cleft, is in alignment, and that there's no rotation on the shoulder. They shouldn't be like, which can indicate a rotational deformity of the spine. So this patient's spine should look good at this time. Also, I can place my hands on the patient's hip. So here, the patient's hip over here, and then hips, and make sure that they are even looking. Or now for a quick check for the limb length. So the limb length, if there's any discrepancies that the one leg is longer than the other, and then I'll go ahead and have the patient back bend slightly. So it's the same here. If you go in the other side, that's just exactly what we're looking for. The hip there, and then you look if there's deformity, if one is longer than the other. Okay, so now Kai, you can face there again, and can you do a back hyperextend? Good. Good. So like a back bend. So that is extension. So can you twist from one side to from other side to the other side? Twist. Okay. Twist. Okay. And then again, with the neck lateral bending, I will have you bend from side to side bend. Okay. Thank you. Good. So pause.